Okay, here goes, right? 4-year-old male child born to non-consanguineous parents, weakness, pallor, shortness of breath, no bleeding from any side, normal dietary intake, normal stools, examination, he's pale, there's no organomegaly, systemic examination is normal, right? This is his peripheral smear. What's your diagnosis? Iron deficiency anemia, right? Hypochromic microcytosis with teardrop poikilocytes, right? Straightforward diagnosis. What tests will you do to confirm the diagnosis? You'll do an iron binding capacity and serum iron. You'll do a ferritin. Nowadays, nobody does a bone marrow for iron. Next, if you have it, you may do a serum transferrin or a transferrin receptor level, right? These are the tests you would do. This particular patient, serum iron is 32, TIBC is 312, percentage saturation is 10.2, ferritin is 4. Hence, complete diagnosis, iron deficiency anemia confirmed by low serum iron, a raised TIBC, low saturation, and a low ferritin, right? This is what happens in the normal situation. 1/3 of your iron binding capacity has iron in it. So 30% is serum iron and 300 is the iron binding capacity. In iron deficiency, the iron binding capacity goes up, the serum iron comes down, the percentage saturation is decreased. Now, in iron overload, please remember that the serum iron cannot go above 300 because that's the iron binding capacity, right? Now, in anemia of chronic disease, what happens is that the TIBC comes down, the serum iron comes down, and the percentage saturation is maintained. This used to be the gold standard. It's a bone marrow with a pearl stain for iron, and you can see there is no iron in the bone marrow. So what investigation would you do to establish the diagnosis in this 4-year-old child with iron deficiency, right? You would check the stool for occult blood. It's negative. You do a urine hemosiderin. It's negative. So what would be the next test you do? Residents, please think and answer in your mind, right? So these are the causes of iron deficiency: nutritional, iron malabsorption, and blood loss. Where can you lose blood from? From the gastrointestinal tract. That is the most common cause, right? Urinary, uterus, and the rarest cause is pulmonary hemosiderosis. So in those days, we were doing a bone marrow in the difficult anemia cases. When we were doing a bone marrow for this kid, he desaturated. At that time, we did a chest X-ray. And this is what the chest X-ray showed. You can make out the miliary mottling. Right? Can you see that? So how will you confirm the diagnosis? Very simple. Early morning, gastric juice, stain it for iron. This is what we found. Loaded with iron-laden macrophages. Diagnosis: pulmonary hemosiderosis. Right? This kid is now 22 years old. He has followed me to Tata Medical Center in Kolkata from Vellore. So I still see him. And we don't know the etiology of this condition. We don't know how to manage it. Earlier, we used to give iron. He's one of the longest survivors as per the literature, and he has no residual damage. He is on a small dose of immunosuppression and inhaled steroid. He doesn't require iron replacement now because his bleeding into the lung has stopped. So I shouldn't have started with the rarest of rare causes of iron deficiency anemia, right? And that's the final diagnosis, right? Now, second is a nurse from Kerala, and she has a hemoglobin of 6, MCV of 65, all her tests show that she's iron deficient. She's been taking iron regularly for the last 6 months and a good dose, but she still remains iron deficient and her bone marrow has no sustainable iron. So this could be a very rare case where she's not absorbing the iron that she's taking orally, right? And a very simple test, 6 milligram per kg of iron as ferrous sulfate. Do the serum iron at the time of administering, 1 hour and 2 hours later. Normally, the serum iron should double after 2 hours of taking oral ferrous sulfate. If that doesn't happen, there's a problem with iron absorption. This lady did extremely well with MC-CARB. Right? Case 3, 23-year-old housewife found to have anemia during her first pregnancy. One of the people working in Vellore when I was there as a consultant. Bone marrow loaded with iron, but peripheral smear absolutely diagnostic of iron deficiency anemia. So what is this? This is a condition called iron refractory iron deficiency. That means there is iron, but the iron is not utilized for producing hemoglobin. It's not uncommon, right? You may see one case in a year, right? Bone marrow loaded with iron, Prussian blue full, right? And these are the rare causes that I've told you. In this particular case, diagnosis was a hereditary condition where she had a problem with her TMPRSS, TMPRSS. Now, for those of you who would love to look into iron, this is the cartoon done by one of my PhD students, which says everything. Iron is absorbed as the ferric form. It cannot be absorbed in the ferric form. So it's converted to the ferrous form. There is a transporter called the divalent metal iron transporter. And this takes the iron from the inside of the enterocyte, and at the opposite border, you have something called ferroportin. And this is what transports the iron out into the plasma. Whenever there is enough iron inside your body, then what happens is that the iron gets deposited in the endothelial, in the duodenal epithelial cell as ferritin, right? Now it comes into the plasma and it binds to transferrin. Now please remember that the red cell can take up iron only if it is presented with transferrin. I have a little girl in Calcutta whom I diagnosed in Vellore. She has hereditary A transferrinemia, right? She does not have transferrin. Does she have lots of iron? Yes. Her serum iron is high, her liver is loaded with iron, but she's not able to take up that iron into the red cell because there is no transferrin. It's a rare condition called hereditary A transferrinemia. How do you treat her? You just give her plasma every month. So the plasma contains transferrin. It will get a wave of reticulocytes, and next month again, you've got to give. Recombinant transferrin is not yet available, right? So the iron which is not required for erythropoiesis then comes and gets stored in the hepatocyte. Here you can see the hepatocyte where the iron is stored as initially as apoferritin, and then it gets converted to ferritin. So in thalassemics, there's a huge amount of ferritin inside the liver, right? Now, when red cells are broken down, as you can see here, the broken down red cells are taken up, the iron is taken up by the macrophages, and then it is released. And the master regulator of this whole process is hepcidin, right? So please remember that and go and read up a bit about hepcidin. One more case and I'll stop. 62-year-old ex-director of CMC, right? And this individual was a heavy smoker. And at the age of 61 or 2, he came to me with a hemoglobin of 11.8 and an MCV of 68. His iron studies were normal. My first diagnosis was a malignancy of the GI tract, right? Commonest cause of anemia in a 64-year-old person who's on a normal diet is a GI malignancy, right? So that's what I suspected. But lo and behold, when we checked, his MCV was low, but his iron was normal, right? He was a person with alpha thalassemia diagnosed at the age of 62. So normally we have 4 alpha genes, right? If one gene is deleted, all you have is a hemoglobin which is around 10, 11 and with a microcytosis. If 2 alpha genes are deleted, again, you have a lowish hemoglobin around 9, 10 with a low MCV. If 3 genes are deleted, then you have hemoglobin H disease. If 4 genes are deleted, then you have hydrops fetalis, you're born with a hydropic baby, right? These are the phenotypes, which I won't go into. How do we diagnose 3 alpha genes deficient? We look for what are known as golf balls on a reticulocyte or a new methylene blue stain. You can see this beautiful golf ball, which is on a new methylene blue stain. And this is diagnostic of hemoglobin H disease or 3 gene deletion, right? Last case, 12-year-old girl with a history of anemia, diagnosed as megaloblastic anemia. Her brother is being investigated, no hepatosplenomegaly. Okay, by the time she came to us, she had been treated. So her MCV was 100, hemoglobin was low, platelet count was normal, white cell count was slightly low. You can get a pancytopenia in a megaloblastic anemia, right? This is a blood film, and you can see there's a pelgo-Huey cell here, but there is macrocytosis. The bone marrow showed megaloblasts with erythroid hyperplasia, right? She had lots of stainnable iron in her bone marrow. And what is this? This is a ringed sideroblast. So in fact, the cause of her anemia was a congenital sideroblastic anemia, right? And it's not a common condition. It's relatively uncommon. And these are the mutations. They are mitochondrial gene mutations. So you inherit these mutations from your mother. So with this, I will stop and thank you, Sanket, for this.